Respected Chairperson and learned audience, I am Dr. Pradip Kumar Karmakar, working as an Associate Professor of Cardiology and ICBD. Welcome you all. Today is my talk, TAVR in Bicuspid valve. I must thank to the organizer to giving me the opportunity. TAVR in Bangladesh is still in the takeoff phase. It is long way to fly in this region. And TAVR is the highest interventional treatment in the field of interventional cardiology. Respect to the audience, most of the audience are our young cardiologists who are going to be TAVR specialists. So I also give brief idea about initial TAVRs and TAVR situation in Bangladesh, then I go to the bicuspid. What the prevalence of aortic stenosis? It is around 7% in the population over the age of 65 in USA. This is the Indian study. It shows, very important, 25 to 40% of Asian population have the bicuspid aortic valve. Even we are doing the aortic valve, and we are getting the more populations regarding aortic valve with severe aortic stenosis. And see, even in Bangladesh, total number of severe aortic stenosis is around 60,000. So we have to start the program meticulously. Then everybody knows how the life-threatening disease the aortic stenosis is progress rapidly. Just see, after the onset of symptom, 50% survive only 2 years and 20% survive in 5 years. So this is another important slide. Just see, 5-year survival of prostate cancer is 30%, ovarian cancer 28%, breast cancer 23%, colon cancer 12%, and the lung cancer is 4%. But see, in severe inoperable aortic stenosis, only 3% 5-year survival rate. And this is the therapy, transcatheter aortic valve replacement is exponential growth throughout the world. Even in 2023, there is more than 2 million TAVR implanted throughout the world. Then the study, what the study shows is a partner 1. It shows TAVR is superior to the medical management. Then the partner A, that Dr. Ramesh said, TAVR is non-inferior or superior to the surgical aortic valve replacement. Then, and the partner 2A shows TAVR is non-inferior, even superior to the surgical aortic valve replacement. And the latest, the 2019, it shows that TAVR is superior to surgical aortic valve replacement. This is one of the golden moment of the world. It is 2022, 16 April, in France, Professor Alain Kibria started the TAVR program. And it is TAVR is the standard of care for majority of the yes patient. It is cited by the Brown Wall. This is another golden moment. What the Dr. Ramesh said in 2019, 16th August, the FDA approved TAVR for low-risk patient. Initially, we started the high-risk patient, then extreme high-risk patient, then high-risk patient, then intermediate risk, then low-risk patient is approved on 2019. Another important change, in 2009, there is a lot of physician, the cardiologist, cardiac surgeon inside the cath lab. But see, in 2023, it is minimalistic. We only did 3 to 4% inside the cath lab because the procedure is simplified, then the result was unchanged, a similar outcome in the long term, and less resource and short hospitalization and reduced cost. Initially, we admit the patient 2 days before, and after the TAVR procedure, on the 3rd day, we release the patient, and on 7th day, patient can work in his office. What is the TAVR in Bangladesh? Situation is Bangladesh. Dr. Kaisab has said is a lot of no. It is only total 16 cases in Bangladesh. Out of that, 10 is done by me and my team. and other 6 in 5 different non-government hospitals in Dhaka. So still we are in the takeoff phase, long way to run to fly. In our experience in 16 cases, in 10 cases, we have tricuspid 5, bicuspid 4, and valve in valve 1. So the lot of cases of bicuspid aortic valve we are getting in this CT era, where it is challenging. The conflicting report of efficacy, no randomized data, still some uncertainty with procedural conduct, and little hesitation about the treating high and intermediate bicuspid patients. This is the problem for the bicuspid aortic valve is a congenital anomaly, but a symptom the patient come to us usually after 50 to 60 years of age, because they have the bulky leaflet which invites incomplete valve expansion, paravalvular leakage, annular rupture, and high ppm rate. Even for TAVR patient, we need the space between the annulus and the coronary height is usually 10 millimeter. But in the bicuspid aortic valve, most often it is less than the 10. So sometimes we have to use the coronary protections. Another thing, the ascending aortopathy is about 25% patient has an ascending aortopathy with bicuspid aortic valve, especially coarctation of aorta. And still the challenges in the device selection and sizing, because lack of standardized sizing and no specific device in bicuspid valve, and large and ovality of the annulus and horizontal aorta. Most of the patient with bicuspid aorta having the horizontal aorta, and more annulus is more oval than the circular. So it challenges with the device delivery, risks of paravalvular leak, risks of early degeneration, and long-time duration of the TAVI valve. For this reason, bicuspid valve had been excluded from all randomized trial. But for the last few years, the worldwide bicuspid aortic valve taken off for TAVR treatment, and still now, though there is no randomized clinical data, but the result is good. There are some studies yet to be published. Still, this is offline indication. The indication is expanding for tricuspid aortic valve. Initially, it was only severe symptomatic degenerative aortic stenosis. But the coming indication that the bicuspid aortic valve and even the moderate aortic stenosis with LV dysfunctions is coming up. See, the bicuspid valve is as 3 types. Type 0, there is no refi. The type 1, it is the commonest in our subcontinent, is about 66% is 1 refi. Is it type 2 is 2 refi. This is 1 refi, this is 1 refi. This bicuspid valve sizing consensus. The panel therefore recommends the sizing of the bicuspid anatomy should continue to based on the primary measure of the annulus. Still, it is as like as tricuspid valve. In tricuspid valve, we measure the valve according to the annulus, and the consensus is the bicuspid also the valve size should be as annulus. That the landing point of the bicuspid morphology, calcified raphe and excess leaflet calcification was independently associated with the increased procedural complication and 2 years all-cause mortality. High risks of then impact of bicuspid aortic valve morphology on outcome consisting the low surgical patient as well as patient who had TAVR is a new generation device. Aortopathy was not independently associated with the all-cause mortality. Still, surgery is a good indications for very young patient, mechanical valve, patient with significant aortopathy and hostile alveolar calcification, because alveolar calcium is one of the massive or severe calcification is alveolar is invite the rupture of the annulus, for it is the one of the contraindication if it is severe, and even the unicuspid valve also a contraindication for TAVR. Then we can use the both valve. We have the balloon expandable valve and self-expandable Medtronic valve. There are some benefits of both valves. In balloon expandable valve, there is high risk of stroke, annular rupture, and the coronary artery occlusion, as there is the height between the annulus and the coronary artery is low, For this, there is a chance of high occlusion is there. In self-expanding valve, there is high risk of pacemaker indications, and paravalvular leakage is high, and it is non-circular deployment may be happen, and tracking to the tortuous in horizontal aorta. And regarding the implantation, usually the valve is implanted 70-30. 30% is in the alveoli and 70% in the aorta. But in the bicuspid aortic valve, it usually balloon expandable valve 90-10 or 100. At the 100 means at the level of annulus. 90-10 is 10% in the alveoli and 90% is in the aorta. And self-expanding is also low depth, is 1 or 1 millimeter depth. There are some cases, bicuspid valve. This case is, we read the case, is the bicuspid valve on 6th, few days, only 3 days ago. And my patient is discharging today. So what are the challenges we are encountering? Is the cost, the high cost. In this subcontinent, we do not have the insurance, so the party have to pay for this season. But in our NICVD, my director sir is there. He is helping us to conduct this program in very low cost than the outside and the private center. And the poor reimbursement, lack of industry, we do not have the valve. Even India had the valve. We do not have the valve or hardware. Lack of structural training, poor heart team concept, and lack of awareness. What is the conclusion? Still, the TAVR bicuspid valve is feasible and safe. Consensus on the annular sizing and better result with new generation device, both balloon expandable valve and self-expandable valve shown to be effective. Hostile anatomy with calcified raphe and leaflet was OATS outcome. Randomized trial with long-term follow-up warranted. This is the NICVD TAVR team. It is the media, print and electronic media. We are making the awareness throughout the country, including the cardiologists, that we have the TAVR program. So if we keep the patient to get treatment in our country, we can serve the patient as well as we can prevent the drainage of our money to outside. Thank you very much for your patience hearing.